Good morning. Welcome you all to our radiation oncology physics course, and we are running in the fourth week of our course. In the fourth week, we are discussing the basic radiation oncology treatment planning and classical radiation oncology. You can say these are the technique of conventional radiation oncology, and today's lecture number is 19, and today we are going to discuss about external beam treatment planning system. Learning objective of this class, we will discuss the aims and objective of treatment planning, the parameter which the things which we need to keep in mind during the treatment planning of cancer patients, and we also discuss the strategies to achieve these aims and objectives, and we will discuss the treatment planning, we will discuss various kinds of combination of fields, and we will discuss the tumor dose specification in this class. Now first, to understand we must remember all these aims of treatment planning or goals of radiation therapy treatment planning, where the first point is we need to deliver the maximum dose to the tumor. This is the first, and we should limit the dose to the surrounding normal tissue as minimum as possible. So this is our first aim of radiation treatment planning. This is the first and foremost aim of our radiation therapy treatment. That is maximum dose to the target volume with minimal dose to the surrounding normal tissues. And the second aim of our planning is that the dose distribution within the tumor should be reasonably uniform. That means the target volume should receive almost uniform dose, and we have a range that is defined, that is 95% to 107% of prescription dose. This is our second aim of radiation therapy treatment planning. These aims are applicable for all kind of radiation treatment in radiation oncology department. And the third point is the maximum dose in the tissue should not be excessive. The maximum dose should not excessive, and they have given the limits of 110% of the prescription dose. So the global maximum dose of any point should not cross 110% of the prescription dose. Means if we want to deliver 100 centigrade dose or 100 centigrade dose, that dose of any point should not cross 110 centigrade. And the uniformity, the dose should be, if we prescribe the 100 centigrade dose, the uniformity should be maintained, that the tumor volume should receive in the range of 95% to 107%, means that the tissues, the target tissue should receive the dose of 95 centigrade to 107 centigrade as the prescription dose is 100 centigrade. And the fourth aim is the normal critical structures. We have multiple critical structures and they have the tolerance dose, and during radiation, if these critical structures receives the dose beyond the tolerance dose, then there will be complication, and these complications are very serious in the radiation treatment. So we should limit the dose of the normal critical structure, and they should not receive dose near or beyond the tolerance dose. As we have the critical structure that brain stem, we have critical structure the optic nerve, optic chiasma, we have the critical structure as spinal cord, the eye lens, the skin, and various other organs such as kidney, heart, lung, and they all have their specific tolerance dose. So during the planning, we should limit the dose or the dose of the normal critical structures should not beyond the tolerance dose. And these tolerance dose are also prescribed in different form. They are maybe the maximum dose, or they are these dose may be defined as the mean dose, or they may be defined as the maximum point dose, or any volumetric dose also may be given. So, these are the 4 points we need to keep in mind during the treatment planning of any kind of treatment planning of radiation oncology department. Now, to achieve this aim, this 4 aim, we need to have some strategies so that we can achieve the aim of this radiotherapy treatment planning, and we can treat our patients safely. And what are the strategies? First one is, we need to select the appropriate beam energy. As you know that in radiation oncology there are multiple beam energies are used. There are multiple photon energies such as cobalt 60 gamma radiations, the 4 MB photon beam, the 6 MB photon beam, the 15 MB photon beam, 18 MB photon beam, and we also have the facility of the electron beams. So, you need to select the appropriate beam energy that is suitable for that patient and the specific type of disease. And next one is, we should select the appropriate field size, means the field aperture or portal aperture should be such that it should only just encompass the target volume which is mentioned by the radiation therapist, radiation oncologist, and these target volume should be covered by the appropriate full field size. And we can judiciously increase the number of fields, that is beam multiplicity. You know that if we increase the field number, we will see that how this beam multiplicity is acting to achieve the better treatment plans, and these number of fields should be judiciously increased. And as we increase the field number, we will get the better dose distribution, but there will be complexity is more, and the treatment reproducibility, these are the factors we need to keep in mind during the treatment planning. Now, the next is appropriate field directions, means the which direction we want to deliver our radiation field. Radiation should be directed such that the critical structures and some other things should be avoided during their path length, the radiation path length. And we may also adjust the beam weights, means if we treat by 4 field, one anterior and one posterior and one lateral, right lateral and one left lateral, we may we may assign the beam weights as per our requirements to get a better dose distribution and of the target volume. We can also use the beam modifiers for betterment of dose distribution or betterment of treatment plan, and these beam modifiers we have discussed in last class. They are OHs, we may use OH, we may use bolus, we may use compensators. So, these are the strategies of our treatment planning by which we achieve the aim of our radiation therapy treatment planning, to get a better dose distribution and to treat patients safely, so that they should not be, we may avoid the complication of the treatment. Now, in treatment planning we use the combination of field, means we can use single field, we can use 2 field, we can use multiple field, we can use one OH field, one open field, we can use both of them OH fields, and these are the combination of treatment planning. Now, the first kind, that is very simple type of irradiation technique, is single field technique, where most of the time here is the source, and most of the time in single field setting we use the SSD technique, where source to surface distance we keep the fixed, that is the 80 centimeter or 100 centimeter as per our treatment machine, and here is the patient or phantom, and you can treat this target. This is very rare situation where we use the single field, because it is not able to produce the good dose distribution, but there are we can still use the single field treatment for the superficial target, such as we can treat the skin, we can irradiate the supraclavicular nodal irradiation also can be done by single field, that they are for during the breast treatment of cancer breast cancer patients, treatment of breast cancer patient. We can use also similarly internal mammary nodal irradiations also done. This is the nodal area which need to be irradiated for the breast cancer patients. We can irradiate the spinal cord. There are craniospinal irradiations, and there may be the pain management or palliation cases where we can use the single field treatment planning. The merits of this type of single field treatment is we will have a very simple setup, and it is reproducible, but the demerits is the dose distribution is not ideal, because the 4 aim which we have described in the first slide, they may not achieved by the single field treatment technique. Now coming to the parallel opposed two field. Here it is not only two field, it is parallel opposed two field technique. This is type of technique where we use that we can treat the pelvic abdominal area where anterior posterior fields are used. They are or in the head and neck cancer or brain irradiation where we can use the two lateral, one is right lateral, another is left lateral. They are the simplest combination of two field techniques. Even they also, this two field technique can be used by can be applied by the SSD technique or by the SAD technique. In SSD technique, we need to keep the source to surface distance fixed, that is 80 or 100 centimeter, and for SAD technique we need to keep the source to target center distance fixed, that is 80 centimeter, source to axis distance. Now in this type of technique we use a pair of field with the same axis. You can see this is the axis is same of both the field. So, and they are directed from opposite side of the target volume. They are directed, this is the target volume, they are directed opposite side from the target volume. So, they are the simplest combination of two field and pair of fields with same axis and directed from the opposite side of the target volume. Now, the merit of this parallel opposed two field technique is, this is very simple type of treatment technique, and we can reproducible the setup on daily basis. We can irradiate the target with homogeneous or uniform dose, which is our aim, one of our aim in treatment planning, and there is very less chance of missing the target if we select the treatment field or treatment portal or treatment aperture, field aperture appropriately. Now, the demerits of this technique is, we can land up with high dose to the normal tissue above and below the target. So, these peripheral structures, these peripheral structures will receive high dose than the target volume. So, this is the one demerits, and we will discuss is in detail of this type of facts behind this demerits of two field technique, as this demerit is high dose to the normal tissues above and below the target. Now, this is known as tissue lateral effect. This demerits is known as tissue lateral effect. If you see, here is two lateral fields are there, one is right lateral and another is left lateral, and this is the depth and this is the treatment prescription area. Now, this right lateral percentage depth dose curve, you can see this is the right lateral percentage depth dose curve, and this is the curve, and this is the left lateral percentage depth dose curve, and you can see this is the mid plane PDD and this is the exit PDD, this is the entry PDD for right lateral, this is the exit PDD for right lateral, and this is the entry PDD for right lateral, and this is the exit point of left lateral. So, if we sum up, we will get with the this kind of, if we sum both these percentage depth dose, we will get this is the sum. You can say, see there is a dip in the center. So, in mid plane we will get a lesser dose than the peripheral area where we will get a horn type of curve. So, this is the tissue lateral effect. You can see from this percentage depth dose isodose charts, where this is the one from we treat one direction from right lateral, left lateral, and another from left lateral. This is the target, and we will get the peripheral dose is higher than this target dose. So, this is the tissue lateral effect. Now, here you can see we use to avoid the tissue lateral effect, we can increase the multiplicity of the beam radiation treatment technique. Here we can use the multiple field we can use the 4 field technique, where we can direct one beam from 0 degree, one beam from 90 degree gantry angle, and one beam from 180 degree and another beam from 270 degree. So, with this, if you see, this is the volume which is superimposed by, this is the area superimposed by all the beams. This is the volume which superimpose the targets. So, this volume will receive the maximum dose, and the other volume will receive the less dose. But this multiple field provides very good dose distribution, but limitation of this field is, this is a complex type of treatment setup, and reproducibility of this treatment setup needs to be very accurate quality assurance and treatment verification system, so that we can accurately treat the patient and we can fix this isocenter daily. This is the isocenter, this is SAD type of technique, where we fix this distance, and a small amount of error may cause very geometric miss. If we miss the tumor, this is a serious issue in the treatment of cancer patients. We will fail our treatment if we miss the target. Now, here is some dose distribution I have shown in this slide, that this is 3 field technique dose distribution. The one field is directed from this side, and another is from right lateral posterior right lateral oblique, and this is another, and we also use the wedge in this 2 field, and you will get a good distribution. This is the target volume, and you will get a very good coverage of this target. Here in this field we have a 4 field technique. You can see the one direction 0 degree gantry angle, 90 degree gantry angle, and posterior 180 degree gantry angle, and 270 degree gantry angle, where you can see that target volume, this red one is target, and this is covered by 95% of isodose very well. And here is also a 4 field technique, but in different directions. These are the isodose distributions are created by treatment planning system. They are computerized treatment planning systems, which are run by very sophisticated and very complex type of mathematical algorithm, and they produce this distribution for us, and we just need to arrange this beam as per our choice, and we will see the dose distribution and we approve our plan. Here another type of display is there. This is known as color wash display, where red one is the higher dose and blue, green and blue are the lower dose. Now, treatment planning, combination of fields, we also need to discuss the wedge field technique. You see, if we use the 2 angled, one beam is from anterior side and another from right lateral side, you can see this point, the both beam only travel this much amount of tissue and this much amount of distance from the source. So, here we will get a higher dose, but if we consider this point, you will get a higher distance and higher tissue travel, and you also get a higher tissue travel. So, this point will get a very less dose. So, if we treat this target uniformly, this is not possible with the open field technique. So, we need to apply the OH. So, we put this thick end in same directions in the and thin end here. So, you will get this high dose is compensated and this high dose is compensated, and this low dose, the batch these are from thin end. So, this at this OH or attenuate this part, and it will sum up with a lesser dose than previous one open field, and this dose will remain same with the previous one. So, this whole target volume will treated by uniform dose. These are the isodose distributions of open field. This is the open field. You can see this is high dose and these are the low dose area, but if we apply the OH, we will get a very good uniform dose distribution for the target volume. And here this diagram is shown for better understanding, where two OHs are separated with an angle, and this angle is known as the hinge angle, and this hinge angle decide which angled OH is required to make this target volume uniform dose distribution. Now, coming to the tumor dose specification, they are defined by the ICRU. Target ICRU is the body which define the target volumes, means what are the targets to be irradiated, it is defined by the ICRU, and we have ICRU 29. They are used in earlier days, where we are used to treat our patients, very conventional type of technique, where they have defined a target volume and a treated volume, which is the volume is having a significant dose of the, and one is irradiated volume. Now, in ICRU 50, it is coming later, and when we develop our treatment techniques, and they have divided this target volume in further subcategories, and these categories are, first one is GTV, that is gross target volume, and then is CTV, that is clinical target volume, and then we have a PTV, that is planning target volume. Now, GTV is the gross target volume, gross disease which is clinically or radiologically we can see the target. This is defined as the target volume. Now, with this target with the target of GTV volume, there will be some microscopic spread of this disease. So, we need to include all this microscopic volume with our knowledge and our previous experience. So, there is a definition of CTV for each type of sites or each type of disease. So, radiation oncologist contour or delineate the clinical target volume, which where the dose is microscopic disease may be there. So, these two combined with the these CTV and GTV combined with this as a target volume, they are gross target volume and clinical target volume. Now, because of daily to daily patient treatment setup, and there may be some machine error, and there may be some other geometric uncertainties there. So, we need to give one more margin, that is the planning target volume, and all these target volume is planning target volume. So, GTV plus CTV plus PTV is target volume of our treatment planning, and we have a treated volume and we have a irradiated volume. Again, Further, the radiotherapy techniques developed to IMRT modern day radiotherapy era. So, there is a need to have considering the internal target motion or internal target movements in the planning target volume, and there is a setup margin. They separated the PTV in internal target volume and a PTV, that is ITV plus PTV. So, this is the total target volume for treatment planning. This is according to ICRU 62. Now, this diagram, it is further explained. You can see this one is gross target volume, and these are actually subclinical disease, and combined with clinical target volume GTV plus subclinical disease is combined target volume, that is clinical target volume CTV, and there is a internal margin. This is the internal margin. They may be uniform, or they may not be uniform in all sides. So, this is the internal margin for the internal target movements. So, we have a target volume ITV. So, CTV plus internal margin is the internal target volume. Again, we need to give some setup margin, that is this is the setup margin, and this is the setup margin, and this setup CTV plus combined internal margin plus setup margin is the planning target volume, and we give the organ at risk volume, and also give the internal target movement, this critical structure may also have some movement. So, they give the one planning organ at risk volume. So, this is PRV volume, and finally, this is the PTV volume, and this is the PRV volume. So, thank you all. This is all for today's class.